My name is Kamlesh Patel, Associate Professor here at Washington University and at St. Louis Children's. And today's aim will be just to provide an update on two main populations that I treat, patients with cleft and patients with craniosynostosis. These are my disclosures. I'm a consultant for Stryker in product design and education, and then a speaker for AO North America, which is a facial trauma education course. So again, these are the two patient populations, and management has been going on for a long time for both of these. But the idea of this is just like what's new over the past, say, 5 to 10 years. So let's focus more on cleft lip and palate, and this is the slide I like to show them just to show what it would take from the first time they appear. Sometimes it might be prenatally, or it could be just a few weeks after life. And how does it end? And the end point is sometimes when they're around 16 to 18 years of age. And my goal is to show them is like what I want to get them through is just the minimal number of operations that I can possibly do during that time frame. And usually these kids need about 4 to 5 operations to get them through. So again, this it starts off with the initial evaluation to the cleft team. This is our team. There's a lot of players in here, and not that every patient would need every single person on this slide, but the idea is you do have to have the full all the specialties and all the team members so that you can actually take care of it, especially the more complex patients. This team, we're fortunate enough through Children's and the Foundation, we actually also have a research outcomes arm with a research coordinator, Corinne, lab manager, and database manager in Gary, and then Cyril Naidu as well as my research partner. And the idea is that if we can't look at outcomes, there's no way that we can continue to evaluate and strive for better outcomes. This is what we give to families when they first come, and actually with every single visit, because we do follow these patients from birth until when they're scale and mature, which is around 16 to 18. And it's nice for them to remember, remind them like where they are on this journey and why they need to come back. So before even doing anything surgical, then there is a setup process for patients with cleft. And one example is nasoalveolar molding, where you do this taping and like a dental mold on the inside. And the benefit is you can take a wide cleft like this and narrow it before any surgical procedure. And in the end, I can do a better job with that bottom right picture compared to the upper right. These are the two options we provide. I'd say this is what we were offering to all 10 plus years ago. But the only downside of this is that it does require weekly appointments and it's higher cost, and it's not really applicable for patients that do travel, say 4 to 6 hours, to come to our clinic. So over the past, I want to say 10 years or so, we started institution, this passive molding device. It's been present actually even before that. It's kind of just bringing it back again. And the benefit is this, is that the appointments are more as needed, and then therefore the costs are a lot lower as well. So we compared the outcomes, and again, you have to look at the outcomes. And what we found is that at least 1 year post-operative, there's no difference in the appearance, and looking at asymmetry of the nose and lip between the two. So now, we feel we can, when we talk to families, we offer either option with their preference dictating which one they may pick. So now the lip and nose repair. There are many different techniques. 2 of them have a St. Louis connection. Brown and McDowell, where I used to work here at St. Louis Children's, and then Milad was a resident at Washington University in plastic surgery. And the goal is just to make sure that you get appropriate height of the lip. And what does that mean? My job is to make sure that this point comes down far enough that it matches up to the other side. So you want to get good height along the white part of the lip, the red part of the lip, and also along the inside as well. This is the most common technique used around the world, and it was actually developed by someone that trained here in the 1950s. Again, lip height is what we're trying to aim for. I got to get that 1 point down and bring it and use the other side to get it to all match up. But there's many different things that you have to think about to get that to match up. I'd say this, even though you can get good lip height, meaning the cutaneous lip height, you can also have concerns with deficiencies of what we call the chapstick area of the lip and also the inside of the lip. And in this paper, what we did was just to show a technique, because we found that most of the papers are very focused on the white part of the lip to get the appropriate height and less so the other two components. So the aim of this paper is just to show like, okay, this is how you do all the steps. And, you know, all these markings, not to get into too much technical detail, allow that to happen. And these are all individual steps. And luckily with an illustrator, this has been very popular around the world to just showcase how the technique is actually done. And that's the aim. You just want to make sure you added some extra tissue with this triangle so it can all be built up. And then again, add extra tissue here. And we looked at that and basically found that once we, with this technique, no revisions and overall asymmetry was very minimal between the two sides. The other part of the cleft lip repair is also the cleft nasal repair. And I'd say in older kids, that's the part that shows up the most in terms of, you know, psychologically for the child growing up with that asymmetry. In this paper I did, boy, it's now 9 years ago, it was just showing the technique of how to basically reduce those cartilages. So the nose is made of cartilage. You got bones up that are higher and then cartilage down below. And how do you actually bring those cartilages together? And how can you do it safely in a young child? This is one of the reasons why I do my cleft lip repair when they're a little bit older, say around 5 months of age. The other reason is just it's an elective operation, and the operation does take about 2.5 hours. So when I talk to my anesthesia friends, they're like, if you can wait until a little bit older, then it'll be a safer operation. So that's why I tend to do more around 5 months of age. And then the other thing, it allows me to get into the nose because the child is also bigger. And this is the aim. You want to take a cleft that you can see, patient with a cleft on the left side, and get them to the point where the nose is symmetrically formed, lip has appropriate height, and then appropriate fullness along the red part of the lip as well. So that's, you know, focusing on the unilateral lip and palate. Now the bilateral cleft lip and palate, that's about 10% of all facial clefts that we see. And they do tend to be more involved. So I think that the treatment is a little bit different depending on the needs of the patient and the family. So what to do when something like this is sticking out so far? Of course, you know, we do the same, sometimes molding and everything to try to bring it back in place. But if it doesn't, I'd say in the past, people used to still go ahead and just repair the lip. I think that's fallen out of favor now. And the idea is that, no, you can't build if the foundation is incorrect. I think it's just like a house. You got to get that foundation right. And what that foundation is, this gum should be down here. It should belong with the rest of the maxillary arch. So sometimes I have to do a setback first as a surgical procedure to bring that back into place. And I'll show the benefits of that. So instead of, I switched the order of the repair. Instead of doing the lip first, I do the palate first with the setback and get everything in position. And this is done around 10 months of age, which is the usual age for a palate repair. And you can see this little bit of extra bone that is within the septum is taken out so it can actually fall into place. And you can see the difference here. There's where the two front teeth will come out, it's sitting there, but now it's actually back into place. But now, as you can imagine, everything is closed. It allows me to close everything. Because unfortunately, if you don't get this hole closed behind here, that's the most common reason why some bilaterals get a lot of operations performed to try to close it. And a lot easier to do a lip and nose repair on the patient on the, you know, after the setback and palate repair than compared to the left image. So that you can do a good job because the platform is in the appropriate position. You can get a good job done with the lip and the nose. And of course, the key thing is everything's closed inside as well. This is another patient where attempts were made at molding, but not tolerated due to the reaction to the taping. And then you can still see is the premaxilla is still in an abnormal position. So I did the same thing: setback first, palate repair, then lip and nose repair, and to switch the order. And that's the only way you can get a good result done with the lip and nose. And the other benefit is that now everything is closed, and you decrease the burden on the family and also the child as well to not have a big hole behind here, because this would be the common thing that would happen if they get the lip repair done first and ignore the hole behind that premaxilla, is then now they need orthodontic expansion when they're age 8, so you have to wait, then set it back and try to close the holes, which is a lot more trickier because you don't have the same access. And that can lead to multiple reoperations as well. So again, I'd say some updates on that is just how the molding is done prior to lip and nose repair, and for the bilateral, not to be afraid to switch the order. Talk about palate repair, and this just shows the normal muscles in a non-cleft, but in a cleft, the palate's a little bit shorter, and the muscles a little bit more in the front. And we've shown that the more work that you do with the muscles, the better the speech outcome, and that's key because if that muscle is not brought together and does not activate when you want to speak, it actually touches the back of the throat, meaning the soft palate touches the back of the throat. Then you have to do a second operation and to help lengthen the palate and put those muscles in a better position. So the more green you see here, that means the less chance that they need that second operation. And that's the main goal of all patients with cleft lip palate, is how can you avoid that secondary procedure. Other things are that there are dead space within when you do the repair, when you bring the palate together and everything. So using fat, actually using buccal fat to fill that dead space has been great. And in this work, they've shown that the fat does stay viable. I think the other thing, not all palates are the same. The patients with Robin sequence get really wide cleft palate, and all palates can be repaired and brought together. But I think it causes more scarring when they're this wide. So now what we do offer is actually just prophylactically putting in extra tissue, and we use the inside of the cheek to do that. And what that does is adds that extra tissue so the palate doesn't heal with too much scarring, and the goal is that way you get a better speech outcome to reduce that secondary operation. So again, palate repair now, what's been the new things been is do more work with the muscle, and don't be afraid to add extra tissue when there is a deficiency. The operations for speech. This is our algorithm. It's currently in press in the Plastic Reconstructive Surgery Journal. And the idea is, again, using that cheek tissue that you can, I'd say before it was it was all based on the gap, meaning how much that palate is moving. If that palate is moving and it's moving quite well, that the gap is quite small, then you just perform a re-repair of the palate and actually just make it a little bit longer. If it was very short and there's a large gap, then then what we say is basically that palate's not working that well. Let's use a tissue from the back of the throat to bring it together. With this new algorithm and using the cheek using the cheek tissue, we say regardless of the size, it's better to use something physiological like making the palate longer, adding tissue. And this prevents the risk of sleep apnea in these patients. And this is how, again, illustrations to show that you can make a cut all the way along the soft hard palate junction, let the muscles go back where they want to be, and now just fill it with with the cheek flaps. And the same thing idea, you can do a zigzag technique as well if you feel like the muscle needs to be reorientated, and again, add tissue to fill that. And this is physiologic. This doesn't increase the risk of sleep apnea compared to some other surgical options. And all in all, in this paper, we showed that most patients actually achieved a normal post-operative outcome, regardless of how much the palate was moving before. So that's covered lip and palate repair, and then the operations for speech. I'm going to switch to the jaw surgery side in terms of what's new. And the idea here, why is jaw surgery done in patients with cleft lip and palate, is because their upper jaw doesn't grow as much. So sometimes we have to bring that forward. And in cases where it's a large movement, sometimes the lower jaw is brought back a little bit. This is an example of one where it was quite a large underbite. So we do use virtual surgical planning, meaning do the computer on the do the operation first on the computer. Use all these numbers to guide where the jaw needs to be. In this case, we did a 2-jaw procedure, moving the upper jaw forward, lower jaw back. And overall, doing the 3D planning allows us to be a lot more precise in the operating room and decrease the need for any secondary procedures. And it just improves the precision and in terms of the outcome. So that tells you kind of where we are with cleft lip and palate. I'd say future directions are more, we're part of a consortium with multiple other institutions, and fortunate enough to get funding through the foundation to be able to look at patient-reported outcomes. And the idea here is when I see a patient coming in with cleft lip and palate, they fill out certain, answer certain questions and everything, and I can see where my patient is. This is an example, patient A, versus all other patients with cleft lip and palate in this database. So then I can focus on, like, clearly this patient is more worried about the nose and the appearance of the nose, or it could be some functional things as well, that we can then tailor that visit a little bit better. We do lose a lot of our patients before they're supposed to graduate from a team clinic, and this is one paper that we looked at, and it basically cleft lip and palate patients, about a quarter of them stop coming by age 4 and about half of them by age 8. And I'll go into synostosis, but it's kind of a similar story. So we've done quite a few things to figure out, like, okay, how can we make our care more patient-centered? How can we decrease the burden across each of these aspects? And I'd say that's been the focus of our team for the last few years. So let's talk about cleft lip and palate. Now we'll go into craniosynostosis, and how often does this one happen? It's about 1 in 2,000, and depending on which suture closes, you kind of know you get a characteristic head shape, so you know which suture is closed. In all cases, what is the treatment? We're just trying to basically normalize the head shape and make some more room for the brain and expand things. And this is an intraoperative example of a patient with sagittal synostosis, how it's widened where we want it to be widened. And this is one where a metopic patient where they're born with a triangle-shaped forehead, and you can see how much it has been widened in the front, and then you use absorbable plates and screws to hold it in place. Those are the bigger, what we call open operations, and there are some minimally invasive options as well, and we've been doing it since about 2006. And in this, the incisions are smaller, usually 1 or 2 incisions. Shorter operative time, we're talking about an hour, if not less, versus the bigger operations can be anywhere between 2.5 to 5 hours. Blood loss is less as well, where only about 5% actually get a transfusion. The biggest difference is that the ones that are treated minimally invasive do require a helmet, because that's what guides the growth afterwards. So we do use this shared decision-making model to help guide the families, and it's on our website, and there's one for each of the 3 most common single suture synostosis. But in terms of talking about the most common one, which is sagittal synostosis, has that characteristic head shape, very long front to back, and then narrow in the back. And you can kind of see that here. And again, sometimes some protrusion in the temporal area. And there's been a few papers. There was a systematic review that was done that came out a couple of years ago. And out of the 10 papers that were reviewed, 4 was from our group. And it basically showed that the same outcomes pretty much between the open and endoscopic operations, with the benefits of decreased blood loss and lower cost and decreased hospital stay. We've shown our experience, over the first 100, and this is just an example of how we used to set the patient up before with beanbags, and now we have this nice little device that holds everything in place. We are looking right now at cognitive outcomes and also head shape outcomes. The head shape outcome actually just got accepted today for publication, and basically it shows that the head shape is exactly the same at school age, regardless of which technique is chosen. But actually, the head growth is a little bit better with the minimally invasive option than the traditional calvareal vault reconstruction. And that's likely due to the less scarring that's caused by the operation. In terms of cognitive outcome as well, no difference at school age between the 2 different options. And this is an example of a 8-year-old, and I think this view shows it best. And that's the goal: is you want to try to get them through where nobody knows that they even had craniosynostosis. So metopic synostosis is about the second most common, and you can see it's characterized by more of a triangle-shaped forehead. The metopic suture is different from all the others because it's when you do a CT scan, it may be closed, and that's perfectly normal because physiologic closure does happen in the first year of life in most cases. So you have to figure out if it's an abnormal closure or normal closure, and you can see on the left, this is what we call physiologic closure, meaning there's curvature to the frontal bone, and that lateral orbital rim is straight up. This is what we call pathologic closure on the right, where it's straight frontal bone. But the main thing I look for is that that there is sloping of the lateral orbital rim, and that's how you tell the difference between the two. So what is the treatment? If you do the minimally invasive option, we try to do it between 2 to 6 months of age. If you do the front orbital advancement, it's anytime after 6 months, with preference more around 9 months, just because of the amount of operating that you need to do. The child needs to be bigger. This example just shows the incision that's used. This one across the hairline, and then this is all the bone that's removed, all up to down to the nose. And again, that front orbital procedure. So we looked at, how wide, and I did this in 2016, but I looked at like how wide do you need to make the bandeau or the forehead to get a better result at when the child is older. And this is about the size, and just to guide surgeons on how wide they should make it, the forehead. For the endoscopic one, again, or the minimally invasive one, you can see the hairline incision and the bone that will actually be removed. And we looked at the difference and compared the outcomes between the two, and this was in pediatrics. And you can see here what it basically showed is that we get the same head shape outcome in terms of numbers, but one of the biggest one that's the difference, and I'd say the most common reason to do a second operation, is this lateral frontal protrusion. It was definitely a lot more common to be present after the frontal orbital procedure versus the minimally invasive procedure. And our hope is that the number of secondary procedures will be a lot lower after minimally invasive treatment. For coronal or anterior plagiocephaly, it's this one does cause more facial asymmetry. So when this suture is closed, one of the coronal sutures, you get orbital, nasal, and jaw asymmetry at birth. And so when you do the front orbital advancement, the goal is to normalize all of that, get that side of the forehead that was flatter and further back, get it more anterior. And this is just an example what it takes at school age. And then there's, as expected, there's also a minimally invasive option where, again, you just remove the fused bone, you put a helmet on, and then have eventually all of that bone gap actually fills in. The orbital improvement is greater after minimally invasive repair. And we've shown that, and also the Boston group has shown that the need for secondary procedures is a lot lower, in particular the strabismus-related procedures. And when we looked at our outcomes as well, it does seem like the minimally invasive option does a better job with facial asymmetry. As you can see here, the nose is now nice and straight, the chin is in the middle, eyes are also symmetric as well. The lambdoid, I think this is key for for pediatricians to know, like, how do you know the difference between one that's caused by synostosis and one that's caused by deformational changes? How I usually do it is I ask the, just look at the back of the head, have the parents hold the child. And in both cases, the right side is flat. But what I look for is, where is the parietal bossing? If it's deformational, the parietal bossing is on the same side that is flat. If it's synostosis, the parietal bossing is on the opposite side. And that's the one that kind of tells you, okay, I need to get a CT and just to confirm that. And you can also feel a mastoid bulge. Just to kind of brief on deformational plagiocephaly, really it started when the Back to Sleep started in 1994. And this is the concept that the skull is very malleable in the young child, can easily be deformed with back sleeping. Now, there's different types between plagiocephaly, meaning causing facial asymmetry and being unilateral, brachycephaly, where it's just flat and it's symmetric, and then versus scaphocephaly, that's caused similar to sagittal synostosis, where it's long front to back due to side sleeping. And these are some risk factors. I won't go into all of them, but torticollis is one that is quite common, especially in deformational plagiocephaly. So reposition is, your options for treatment are repositioning and also helmet therapy for the ones that are more severe. But none of it's required. I tell the families it's more, it's a personal decision whether to do the helmet or not. And, we've looked at it and found that basically in both cases, if you do repositioning or helmeting, the head shape does improve, but a bit more guaranteed with the helmeting. It's just an example of the outcomes that are expected. So usually take-home points for the helmeting is, refer by 4 months of age. Younger is better because that means less time in the helmet. And usually there's, when families ask, is there any pain wearing the helmet? Not really. And in most cases, a referral actually is not even needed for deformational plagiocephaly. To go back to the lambdoid, again, it's the mastoid bulge and contralateral parietal bossing is what's, as opposed to ipsilateral parietal bossing for lambdoid. When we compare outcomes between open and endoscopic, you can see here preoperatively using 3D for symmetry as a measure. In most cases, symmetry can be obtained, but can still be present, especially after the open operation. So and this is in press, just showing a technique of how to perform the open operation safely, and also ways to improve the symmetry as well. So going to the more complex ones, which is, your multi-suture synostosis, and bilateral coronal is a very high percentage to actually have a genetic diagnosis, up to 75%. Frontal orbital advancement is an option. Sometimes it's a little bit different from the others with, you may have to bring the forehead down a little bit and how much you can actually bring the forehead forward, and you try to do as much as you can. The other option, again, as opposed to frontal orbital advancement, is a minimally invasive option. Again, just removing the fused suture, as you can see here. And in this case, this was not no underlying syndrome, that this was the only operation that was actually performed in this child. The helmeting is key, and we've gone through some different designs, but we're always in constant communication with our cranial orthotist and the overall design team to make sure we get the best outcome. When we compare them, and this is putting our data together with Boston group as well, pretty much get the same outcome for bilateral coronal, whether you treat it with frontal orbital advancement or an invasive repair. For other multi-suture as well, we've kind of, adapted what we've learned in single suture synostosis, and this one is metopic and sagittal combined, did the same thing, just remove the fused sutures, and essentially no additional procedures are required in the 3 patients that this we performed this procedure in. And when you compare this to traditional open techniques where it's 2-stage, 2 large operations, 2 ICU stays, this does decrease the financial and treatment burden on the families. And then we're working on this one right now where it's right coronal and sagittal, and these are twins, and one of them had it and the other one didn't, and that's the aim, is to see if we can get them through that. And this is with a minimally invasive approach. So this is our algorithm that actually just got published last month. And whenever a child presents with syndromic craniosynostosis, our preference is to see early. And the idea then is that we can offer a strip minimally invasive repair. If they get a little bit older, there are some different techniques can be used. And again, we have to continue to follow these patients because they may need additional operations due to increased intracranial pressure or eye protection. But overall, the syndromic population do need to be followed until scalp maturity. There's a big cost saving in performing minimally invasive repair, and it's around $40,000 per case for the first year of treatment. And we use this paper whenever we have any problems with insurance coverage, especially helmet coverage. Cost savings are quite large. Since 2006, we've saved about 11 million plus for healthcare expenditure due to doing minimally invasive approaches in these patients. And I'd say that number is a lot higher because it doesn't include the decrease in secondary procedures. Our catchment area is quite high. I need to add Texas to this list as well. But partnering with the cranial orthotists, and we actually try to meet once a year. And the idea is more of an exchange of ideas to see what helmet design can be used so that regardless if someone presents in St. Louis versus someone in Oklahoma or wherever they are, that they get the same outcome. I think some future things that I'm kind of working on, and I think, fortunate to have all the team members here at Children's and at WashU is, right now our for diagnostic purposes, CT scan is still the main to go. And, the downside is the radiation exposure, with children under 5 being the ones at greatest risk. For my population, I'm getting CTs sometimes as young as 1 to 2 months of age. Sedation often isn't needed, but you do have to do it in some of the, in that 6 month to 5 years of age to get a good quality scan. MRI is great because there is no radiation, but you do often need sedation, and it doesn't seem to do a good job for bone and more for soft tissue. So we've developed this team and it's collaboration between plastic surgery, neurosurgery, radiology, to work together to how do we tackle this problem? How can we actually image bone using MRI? And this is an example of a sequence that's called Black Bone that's out of Oxford in the UK. And overall, it's okay, but it's not as clear, the image. Well, this is one sequence that we've developed, and it provides better contrast between soft tissue and bone. And this is actually my daughter when she was 5 that actually did the research scan. Had a few publications on this with the idea of comparing CT to MRI, and been fortunate to obtain funding through the NIH. And now we're in our second year of 4 to make this a reality. And these are the aims. The idea is to kind of how to motion correct the images. So even if the child moves, we can motion correct them because we don't want to use any sedation, get the scan time down to 1 minute and automate all the processing. And these are just some examples of 1 minute sequences. Of motion correction, where you can see there is no motion. Motion. This patient has motion here. Then we correct them where it looks like just the same as the ones on the left. And then working on 1 minute sequences, we're still in the process for that. This is a 5 minute option here, and these are 3 different 1 minute sequences. And then to also automate the processing so that wherever you are, it's just a push of the button on the MR scanner to produce the clinically useful images. So hopefully you get a good update for a cleft lip and palate and synostosis. And I'd say in both cases, the goal is how can we decrease those secondary procedures? What can we do at the initial operation? And especially with craniosynostosis is early referral, so we can offer the minimally invasive option. Can't do this alone. This is all part of the team. And I think I'm very fortunate to have all the different team members here. And again, the research network does extend beyond my geography here, and I think you do have to partner with our institutions, and we've been lucky that we've been able to do that as well. So this is my contact information. Always feel free to contact with any questions, and always have to thank the foundation for allowing us to investigate our outcomes. Thank you.